Module 18, Osseodensification and IDR. Another possibility to improve implant primary stabilization is the association of IDR and osseodensification in cases with low bone density or the combination of severe bone loss and low bone density. Let's have a look at three different scenarios. In this first situation, we have the presence of low bone density in intact sockets. The second, we have low bone density in compromised sockets. And the third one, the periodontally compromised tooth and severe bone loss. Let's pay attention how we manage these three different clinical cases. Let's start talking on the cases that present low bone density in intact sockets. In this case, this patient presented the right central incisor condemned to be extracted. He presented a thin periodontal biotype. And here you can see that the crestal bone was still present. This is why it was treated as an intact socket. Take a look at the porosity of this bone behind and beyond the apex of this root. After the tooth extraction, here you can see the preservation of soft and hard tissue. It was removed the granulation tissue and the remains of periodontal connective tissue. And here I want to call your attention to the preservation of the gingival margin and papillary height position. And this X-ray was taken right after tooth extraction. It was taken bone from the same side of the problem, the right side. We used chisels and this bone was crushed because here we don't intend to restore any wall loss. That's why all bone harvest from the right maxillary tuberosity was crushed in order to reduce the size of these particles. This picture was taken right after the suture. And here you can see inside this container, we have bone and we have blood to promote a better and faster bone graft incorporation. After minimally invasive dental extraction, it was performed the implant site preparation, always seeking the palatal wall, using the Dunsabar kit in a counterclockwise rotation. Here we are densifying bone through compaction of autografting. And after site preparation, it was packed bone inside the socket. But take a look that we kept the last drill in position to allow us the bone compaction. And after bone compaction, you can see the X-ray that was taken right after this step. And here you can see before and after bone filling. And pay attention that we didn't lose any empty spaces around this drill. This X-ray was taken right after we removed the drill from the position. This picture was taken right after the drill was removed from the bone bed and the implant was inserted, and we got the primary stability over 40 Newton centimeter. And we evaluate the width of the bone at the buccal aspect of the implant. And here we have 3 millimeters in thickness. We have already discussed about this before, and that's the key to succeed with the IDR technique, to leave around 3 millimeters of bone at the buccal aspect of the implant. It was accomplished, the provisional restoration, using the same crown from the patient. We trimmed the inner part of the crown and we added composite resin at the cervical area of the provisional restoration and the palatal aspect. After finishing and polishing, here you can see, if we do a simulation, the 3 millimeters of space left at the buccal aspect of this provisional restoration. And we installed the provisional restoration over the implant, and this X-ray was taken right after provisional crown insertion. And here you can see that the anatomical shape of the provisional crown at the proximal aspect didn't have any contact between the crestal bone and the provisional. And pay attention also the correct three-dimensional position of the implant between the cingulum and the incisal edge of this provisional crown. 3 months after soft and hard tissue is healed, you can see the maintenance of the anatomical contour of soft tissue. We remove this provisional restoration and you can see here a relevant thickness of this periodontal tissue. The soft tissue emerged from the head of the implant. This is why I recommend you to use a platform switching implant. At this time, we measured the gingival thickness, and here you can see around 4 millimeters in thickness. Just to keep in mind how everything started, we have barely half millimeter in the beginning. And here the whole sequence, using the IDR and osseodensification. We have an intact socket. It was performed the bone bed preparation, bone filling, the implant bed, implant placement, and the soft tissue maintenance. And pay attention that the periodontal biotype was improved. And I can say that the soft tissue still remains in the same position due to the presence of the bone at the buccal aspect of the implant. And here you can see the biotype conversion. We start with a thin periodontal biotype, and now you can see a thick periodontal biotype. The impression was taken, a customized ceramic abutment was made, and take a look at the correct ideal emergence profile of this final abutment. We left a slightly concavity not only at the buccal aspect, but especially in the proximal areas to promote the papillae accommodation. The finishing line of this abutment was left half millimeter below gingival margin. Here, during the final crown insertion, a screw retaining porcelain crown, pay attention once more the correct anatomical contour of this final restoration in the most important area of this porcelain crown, the cervical area. These pictures were taken right after crown delivery. And here you can see the X-ray. And take a look at the distance between the head of the implant and the gingival margin. We have around 3 millimeters in height. 1 year post-op, everything is going quite well. The soft tissue is being maintained in the same position, and we have the balance between the natural teeth, the crown, and the soft tissue. This CBCT scan was taken after 2 years. And we can measure, as we discussed before, the buccal palatal distance of this area from the inner part of soft tissue, from the buccal to the palatal aspect. And we can make a comparison in 2 different ways, using the previous CBCT scan or the contralateral side. If this measurement is equivalent, it means that we didn't lose volume in soft tissue at the buccal aspect. And pay attention to the thickness of soft tissue. It's quite relevant. And let's take a look at this square that we call a magic square. Just a quick review. The most important side of the square is the 3D position. We have to respect the correct three-dimensional position of the implant in order to succeed. The second, the thickness of the new buccal bone wall. It's around 3 millimeters. The corneal apical position of the implant, that should be placed 3 millimeters at the apical direction. And the thickness of the soft tissue, that must be equal or more than 3 millimeters. So we have a square, but the main number of this square is 3. Don't forget it. In this second clinical case that I would like to share with you, we have a low bone density in compromised sockets. Let's follow this case. The hopeless tooth was the lateral incisor. We have the presence of an abscess, So it was recommended to prescribe antibiotic therapy 5 days prior to the surgery. Through this CBCT scan, we noticed that we have the partial loss of the buccal wall. This is a defect type R2. So we have to treat this case as a compromised socket. And pay attention to the bone density. We have low bone density beyond the root apex. Now, how to improve implant primary stability in such a very challenging clinical case like this? So first of all, it was measured the probing depth. We have here around 1 centimeter in height. The tooth was extracted, the socket was cleaned, and it was confirmed the loss of the buccal wall. At the same stage, we measured the gingival thickness, and we have here around 0.5 millimeter thickness. Now it's time to take the decision if you intend to compensate with a soft tissue graft or not. Of course, when we use IDR technique, in such a case like this, you don't need to add connective tissue graft. We have the right indication for that. And we are going to discuss about the use of triple graft in the next module. It was performed the site preparation according to the manufacturer instructions. And we know that we were facing with a low bone density. So we tried to insert the implant, we tried to stabilize the implant after site preparation, but we did not succeed. The primary stabilization was under 20 Newton centimeter. What we did, we removed the implant from the socket, we put in a housing, and we went straight to the tuberosity from the right side, for the same side of the problem. We used curved chisels to take the bone. All bone that was harvested from tuberosity, it was stored in a container, and we started bone reconstruction. First of all, we reshaped the graft according to the defect shape, and we insert a block bone graft at the buccal aspect of the socket to restore the buccal wall lost. Here, right after cortical cancellous graft insertion, and after that it was packed particulate bone graft, only particulate bone graft as a bone filler, and we fully filled the socket using either cortical cancellous graft to restore the wall that the patient lost, plus particulate bone as a bone filler. Immediately after that, if we press the periodontal probe at the buccal aspect, the soft tissue won't change. It's because the bone graft is holding the soft tissue in the same position. And this X-ray was taken right after it was performed the socket reconstruction. And remember that we stepped back. So now it's time to do the site preparation again. It was used the densa drills in a counterclockwise rotation with low irrigation and low speed rotation. And we left the drill in position, and we used this drill as a space maintainer. And right after the drill was removed from the bone bed preparation, pay attention here that the osseodensification creates a smaller hole than drilling due to the bone plasticity. We reinstalled the implant, the same implant again, and we got a very good implant primary stability. Here you can see the implant in position plus the bone graft at the facial aspect of this implant. We checked the 3 millimeters of bone restored, and the primary stability was over 40 Newton centimeter. What's next? The next step, we can make the provisional restoration. That's why it was inserted here a provisional abutment over the implant. And take a look at the position of the implant placed here. We are expecting to leave the hole the little hole at the palatal aspect between the cingulum and the incisal edge. We bevel this abutment, we check the occlusion, and we check the veneer at the facial aspect of this abutment. Let's focus in this image. Here we can see that we have the presence of these two edges at the mesial and the distal aspect. So it's recommended to cut, to trim this area in order to avoid any contact between the provisional restoration and the bone ridge, the mesial and the distal aspect. As you can see here. Now it's time to make the provisional using the veneer and composite resin. After finishing and polishing, we check this provisional restoration onto the implant. And of course, we left this provisional restoration shorter than the neighboring teeth to protect this provisional over the implant from the occlusion, from the antagonist arch. Pay attention to the correct three-dimensional position of this implant. And 3 months after we apply the IDR technique, we can see here the soft tissue is completely healed. And let's pay attention in this area, the cervical area of this provisional restoration. Remember that we discussed it before on the soft tissue gap, the importance of soft tissue gap to get a thicker soft tissue at the most important area of the implant, at the cervical area. And this anatomical contour, this concave contour, allow us to get a relevant thickness of soft tissue right here. So the bone graft and the crown's emergence profile guide the position of soft tissue. And here, all the sequence. We had a bone defect. It was performed the bone reconstruction, the bone bed preparation, implant placement, and we got soft tissue maintenance. And the periodontal biotype was improved. We started with a thin periodontal biotype. Now you can see a thick periodontal biotype. It was manufactured a screw retained porcelain restoration with ideal emergence profile. Take a look at this concave contour at the buccal aspect of this final restoration and right after final crown delivery. And this is the post-op after 4 years. We have here the soft tissue maintenance. We made at this time another CT scan. Let's make a comparison how everything started. We have the bone loss at the buccal aspect. And now you can see that the bone graft that was placed over the implant platform remodeled and is still stable over the implant platform. Here you have the 3 millimeters of the new buccal bone wall. And remember the importance of the magic square to succeed with the IDR technique. To finish this model, I would like to share with you a case that presented a periodontally compromised tooth and severe bone loss and how we manage that. Here we have the first molar condemned to be extracted. This is a periodontally compromised tooth. And here the CT scan from this condemned tooth. We have only a low remaining bone at the interdental septum. And now the question is it possible to get very good implant primary stability using a clockwise rotation? Of course not. If we do the site preparation and a clockwise rotation, we will remove all the interdental septum. Now let's follow this case and let's have a look how we manage that. We split the roots in 3 pieces. The palatal, the mesial, and the distal, and we remove one by one. Our goal here was to preserve the interdental septum. Here you can see the crown and the roots, and we intend to use this crown to make our provisional restoration. And after tooth extraction, the socket was cleaned and we preserve the interdental septum. At this stage, we measure the gingival thickness. We have barely half millimeter thickness, and it was confirmed the loss of the buccal and the palatal walls. After tooth extraction, it was performed the site preparation in a counterclockwise rotation using the Danza burr. And here you can see the whole sequence from 2.0, 3.0, and 4.0 diameter of these drills. And pay attention that we improve the size of the hole from 2.0, 3.0, and 4.0. But we didn't waste any bone. The bone is still present all around the bone bed preparation. We took x-rays right after we used 2.0 and 4.0 drills. And pay attention to the increase in the size of these holes. And this is our goal, to densify bone all around the site preparation. As you can see through this animation, as soon as you go inside the bone is going to be densified in the lateral position in the apical direction, as you can see through this X-ray. After site preparation, the implant was inserted. This X-ray was taken right after implant insertion. We inserted here a 4.3 millimeter diameter, and we got the primary stability of 50 Newton centimeter. Now it's time to make our provisional restoration using the same crown from the patient. We open a hole exactly in the center of the crown. We etched and we apply composite resin in increments. So we reline the cervical area of this provisional restoration using composite resin. We check this provisional restoration onto the implant, and after that, we went to the next step. We harvest bone graft from maxillary tuberosity. We just move bone from here to here. So the flap was reflected, and take a look at the amount of bone that we have available all around this area, from the outer aspect of the tuberosity and behind the wisdom tooth. The graft was taken using curved chisels. It was harvested 2 pieces of corticocancellous graft to restore the buccal and the palatal walls, plus some small pieces of bone. All bone that was harvested, it was stored in a container, and we start bone reconstruction. First, we restore the palatal wall using a corticocancellous graft with the cortex turned towards to the inner part of soft tissue and the cancellous part to the implant body. We have to accommodate and to stabilize this graft by juxtaposition. Here, right after palatal corticocancellous graft in place. And after that, we restore the buccal wall using another piece of corticocancellous graft. To finish the bone reconstruction, it was missing to use the particulate bone graft as a bone filler to completely fill the socket, to fill the area around the implant. It was performed the suture only in the donor side. This is what we did. We moved bone from the tuberosity to the receptor site. After bone reconstruction, the provisional restoration was installed, shorter than the neighboring teeth to protect this implant from the antagonist arch. And the sutures, as I said before, were performed only in the donor site. Here you can see, right after the site preparation, the bone was densified in the lateral position and the apical direction, and through this X-ray, you can see the presence of the bone all around the body of the implant. This is the immediate X-ray. This CBCT scan was taken 1 week after the procedure was finished, and you can see the presence of bone all around the implant. This is the follow-up after 3 months. We removed this provisional restoration you can see a very good quality of soft tissue around the implant. As you can see from the frontal view, lateral view, and the occlusal view. The improvement in soft tissue quality, and we have the maintenance of volume of soft tissue. If we make a comparison at the beginning and 3 months later, we have around 0.5 millimeters in thickness. And now you can see the improvement in soft tissue quality and thickness. After final crown in place, a screw retained porcelain crown, we have the clinical view, the X-ray, and the CBCT scan. And this is the post-op after 4 years. Just make a comparison before and after 4 years. Here you can notice the thickness of the new buccal wall and the thickness of the new palatal wall. Remember how everything started. It was remaining only the interdental septum. And we have the severe bone loss in both sides, the buccal and the palatal sides. And 5 years post-op, we have the maintenance of the anatomical contour of soft tissue and the maintenance of the papillary height and the gingival margin position. This is an article that was published on this topic, Osseodensification and IDR, in 2019 by the International Journal of Periodontics and Restorative Dentistry. The use of the immediate dental velar restoration technique combined with osseodensification in periodontally compromised extraction sockets. In this module, we've seen the importance of using the association of IDR and osseodensification in cases with poor quality of bone, despite the kind of socket that we are dealing with, being intact or compromised.